Greetings, ladies and gentlemen, esteemed guests, and also my respective colleague. In today's occasion, I am happy to present you our student project from our small group discussion, which entitled Basic Pharmaceutical Medicine and Drug Ethics. Next. So these are our members of our small group discussion. To be exact, it's the small group discussion B8. There are 12 of us, and you can read it by yourself. Next. So in our presentation today, we'll be covering from the problem of a case, suitability, therapeutic objective first, and then suitability, prescription, evaluation, communication, information, and education, and also, last but not least, the reference. Next. So the case is there is a 7-year-old boy who was diagnosed with acute otitis media, also known as AOM, on the sinistra side, and he felt pain on his left ear for 3 days. Physical examination on his left ear showed eardrum or tympanic membrane still intake, but bulging and looked cloudy. There was no discharge on his ear, and his body weight is 15 kilograms and body temperature is 38.5 degrees Celsius. He has no allergic to medication, but has similar condition about 3 weeks ago. Next. So without further ado, let's start with the problems of the case first.
Okay, let me introduce myself first. My name is Putu Ayudhea A with 3 last digit name number 164. I will explain about the etiology of the acute otitis media. So a variety of causes have been associated with acute otitis media, including middle ear cleft biology. Anatomical differences between individual nasopharyngeal cell biology and variations in immune response to microbial infections, viral pathogens, bacterial pathogens, and genetic factors are all believed to be involved in AOM. However, bacterial pathogens such as gram-negative enterobacilli, particularly Escherichia coli, Staphylococcus aureus, and others are believed to be the main cause of AOM. Next. Okay, so now we'll talk about the pathophysiology and complaints. Pathophysiology of otitis media begins as an inflammatory process after viral infections of the upper respiratory tract, affecting the mucous membranes of the nose, nasopharynx, middle ear mucosa, and eustachian tube. The anatomy of the ear canal in younger children is more prone to infections because of its immaturity, usually short, straight, and wide, becoming more oblique as they grow. That is why acute otitis media usually happens to children. And for the complaints, patients with acute otitis media usually come with ear rage, discharge from the ear, hearing loss, ear popping, ear fullness, dizziness, and fever, also insomnia, loss of appetite, and loss of balance. AOM can result in permanent hearing loss if not treated. Next.
Okay, I will continue about the symptoms of acute otitis media. But before that, allow me to introduce myself. My name is Evrilla Deidree, and the 3 last digits of my student number is 163. For the symptoms of acute otitis media, the first one is unusual irritability, difficulty sleeping or staying asleep, tugging or pulling at one or both ears, fever, especially in infants and younger children, fluid draining from ears, loss of balance, hearing difficulties, and ear pain. And there is a note for acute otitis media in children can present with non-specific signs and symptoms, which can make the diagnosis challenging. Next. And now we'll be discussing about the physical findings and history of acute otitis media. For the physical findings, there are a number of tools that are available to aid the diagnosis of otitis media. The most reliable one is pneumatic otoscopy. In acute otitis media, the tympanic membrane may be erythematous or normal, and there may be fluid in the middle ear space. Examiners will check the external auditory canal for sediment impaction, foreign objects, canal edema, erythema, and otorrhea. The external auditory canal may be somewhat edematous. And for the history, the only sign of a septic focus in a newborn may be irritability or trouble feeding, and most children who are older, will start to exhibit otalgia or ear tugging. Next.
Okay, therapeutic objective. Next. Before I explain the therapeutic objective, let me introduce myself. My name is Yanti Graciella, with my last 3-digit NIM number is 162. So the therapeutic objective is a specific target aimed at improving health, enhancing function, or alleviating symptom in an individual's physical body. The therapeutic objective refers to the desired outcome or goals of therapeutic intervention or treatment. The administration of this therapy is determined based on the individual condition, needs, and treatment objective. After patient is confirmed to have AOM, the treatment will be initiated with the aim of reducing the pain, treating of the infection, alleviating the inflammation, and preventing recurrence of the condition. The first necessary treatment is managing the patient pain. This can be achieved by giving patient the correct dosage for paracetamol, ibuprofen, or benzocaine. To address the inflammation, anti-nonsteroidal inflammatory drugs or NSAID or acetaminophen may be used. Additionally, if there is clinical evidence supportive AOM, oral antibiotic will be prescribed to comprehensively treat the bacterial infection. The first choice antibiotic option include high-dose amoxicillin or second-generation cephalosporin. Next.
All right, for the next one is, but first let me introduce my name first. My name is Herberth, the 3 last digit number of 196. So to be continuing from Grace of the therapeutic objective, first, if tympanic membrane perforation is detected on patients, treatment should be continued with topical antibiotics such as ofloxacin, as it provides higher antibiotic concentration without systemic side effects. And when bacterial causes of AOM are suspected, high-dose amoxicillin can be given for 10 days in both children and also adults. Furthermore, alternative drug options for someone allergic to penicillin are as follows. First is azithromycin at a dose of 10 milligrams per kilograms. This is used every single dose. And second, there is clarithromycin at a dose of 15 milligrams per kilogram per day, divided into 2 doses. Cefdinir, which has 14 milligram per kilogram per day in 1 or 2 doses. Cefpodoxim, 10 milligram per kilogram per day, which taken once daily. Cefuroxime, 30 milligrams per kilogram per day in 2 divided dose. And if there is no improvement after administering high-dose amoxicillin, treatment will be continued with high-dose amoxicillin with clavulanate. Additionally, the use of ceftriaxone, which is 50 milligram per kilogram per day for 3 consecutive days, is used intravenously or intramuscularly can be considered if oral antibiotic administration is not possible. Next. And
What if the patient doesn't recover? So, knowing that the patient has experienced AOM with effusion for 3 weeks, it is also important to consider preventive measures to prevent AOM from recurring in the patient. This can be achieved by planning and discussing the patient lifestyle with the parent in order to avoid AOM triggers. Some strategies that can be implemented in this case are including avoiding exposure to tobacco smoke and administering pneumococcal conjugate vaccine to the patient. Next.
Okay, first let me introduce myself. My name is Putri with last 3-digit NIM number is 167. So for the suitability, next. The first one is pain management. This is efficacy group of analgesic and antibiotic for controlling the pain, which consists of the paracetamol and NSAIDs group. The efficacy in inflammatory reduced paracetamol is worse than the NSAID group. But when it comes to pain reduction, paracetamol and NSAID have the same effect. Next. For the pharmacokinetics of paracetamol, absorbed from the gastrointestinal tract with peak plasma concentration occurring about 10 to 60 minutes after oral administration. For the pharmacodynamics, inhibition of cyclooxygenases enzyme such as COX1, COX2, and COX3. And the side effect is reversible increase in hepatic enzyme for therapeutic dose and dissonance stress and damage cells on the brain for higher dose. And the contraindication, severe hepatic impairment, severe active hepatic disease, and hypersensitive reaction to acetaminophen, but it's rare. Next.
Okay, I will continue the presentation. My name is Nadira with my last digit number 160. So the next group will be NSAID. So the efficacy will be pharmacokinetics and pharmacodynamics. The first is aspirin is really readily absorbed and is hydrolyzed in blood and tissue to acetylene and salicylic acid, while other NSAID drugs are well absorbed after oral admission, such as ibuprofen, naproxen, and piroxicam. And for the pharmacodynamics will be inhibitor of cyclooxygenases. And for the safety will be aspirin have side effects such as gastric upset, gastric ulceration, upper gastrointestinal bleeding, and renal effects, while other NSAID have side effects such as gastrointestinal disturbance, lower than aspirin of course, renal damage, serious hematologic reactions, myocardial infarction, and stroke. And for the suitability would be aspirin have contradictions such as intestinal nephritis, metabolic acidosis, dehydration, hypertonia, Raynaud's syndrome, and etc. While ivermectin could cause pulmonary depression, and all NSAID drugs can cause renal damage. And note that pregnant women are actually hypersensitive to ibuprofen and other NSAID drugs, so it is not recommended for pregnant women. Next. So according to the comparison between paracetamol and NSAID, we choose NSAID as the effective group. And here are the comparison between some drugs within the group of non-selective COX inhibitors of the NSAID. In here we have aspirin, ibuprofen, ketoprofen, indomethacin, and piroxicam. And in here we also divide it in the efficacy, safety, and suitability, and of course the cost. Next. So the conclusion will be we recommend a 100 milligram ibuprofen syrup consumed 3 times a day with 1.5 teaspoon at a time. Next.
Hello everyone, my name is Patricia Orlyn Jotan with 171 as the last 3 digit of my student number. Now for the antibiotics, this is the efficacy comparison between groups of antibiotics against common AOM bacterial pathogens. There are penicillin, cephalosporin, trimethophorin, sulfametosazole, and macrolides. Next please. Okay, for the first antibiotics is macrolides. For the efficacy, pharmacokinetics, good oral bioavailability, elimination of erythromycin is via biliary excretion with the half-life of 2 hours. As for the pharmacodynamics, erythromycin is effective against gram-positive cocci, but not penicillin-resistant Streptococcus pneumoniae strains, and beta-lactamase producing Streptococci, but not methicillin-resistant as aureus strains. Azithromycin has a similar spectrum of activity, but is more against H-influence, Moraxella catarrhalis, and Neisseria. As for the safety, the side effect of it is anorexia, nausea, vomiting, and diarrhea are common. For the suitability, the contradiction is prolonged QT intervals, patients due to their arrhythmogenic characteristic. Also, in pregnant women, specifically erythromycin, due to the possible side effect affecting the mother or the newborn. For the drug interaction, its adverse effects, especially with erythromycin, include gastrointestinal irritation via stimulation of methylation receptors, skin rashes, and eosinophilia. Hypersensitivity-based acute cholestatic hepatitis may also occur with erythromycin isolate. As for the cost, erythromycin is 500 milligram for around 2,000 rupiah per tab. As for azithromycin is 500 milligram with the cost of 12,000 rupiah per tab. Next, please. As for the second antibiotics is penicillin, with the efficacy pharmacokinetics varies in gastric acid resistance and bioavailability, with half-life 30 minutes till 1 hour, minimally metabolized. For the pharmacodynamics, effective against gram-positive cocci, gram-positive rods, mostly anaerobes, and gram-negative cocci, potentially reduce efficacy against penicillin-resistant bacteria. As for the safety, the side effects is generally well-tolerated hypersensitivity reaction, also nausea and vomiting. For the suitability, the contradiction is allergic reaction and Stephen-Johnson syndrome. For the drug interaction is sulfonamide, erythromycin, and chloramphenicol probenecoid due to the blockade of tubular secretion and a decrease in the volume of distribution. As for the cost for amoxicillin is around 3,000 till 21,000 rupiah per 10 tab for oral tab, around 250 till 500 milligram, and 7,000 till 33,000 rupiah per 1 flex 20 millimeter for dry syrup. That's all from me. Thank you.
Okay, let me introduce myself. My name is Wildan from Mahsyar with the last name number is 174. Now we're at cephalosporins. For the efficacy, most cephalosporins can only be administered parenterally. For the oral bioavailability is 85 to 90%. It's eliminated rapidly and mainly by the kidney from active tubular secretion. For the pharmacodynamics, cephalosporins that can be used in AOM are second generation cefproxim and the third generation cefdinir, cefpodoxim, and ceftriaxone. The second generation have coverage against hemophilus influenza, Moraxella catarrhalis, and Bacteroides species. Third generation have less coverage against most gram-positive bacteria, but have increased coverage against hemophilus influenza. For the safety, cephalosporin have low toxicity and generally safe. Most common adverse reaction are nausea, vomiting, lack of appetite, and abdominal pain. For the less common reactions are hypersensitivity, drug-induced hemolytic anemia, disulfiram-like reaction, vitamin K deficiency, and pseudomembranous colitis. For the suitability, the contraindication is allergic reaction and anaphylactic to other beta-lactam antimicrobials. For the interaction, probenecid can reduce the active tubular secretion, resulting in prolongation of the half-life. For the cost, cefdinir in 100 milligram is about 21,000 rupiah per capsule, cefproxim for 21,000, and ceftriaxone injection is 15,000 per vial. And now trimethoprim sulfamethoxazole. For the efficacy, it can be given orally or intravenously. Well absorbed from the gut, distributed widely in the body fluids and tissues, including cerebrospinal fluid. Sulfamethoxazole is metabolized by CYP450 and it is a CYP2C9 inhibitor. Has a half-life of 6 to 12 hours, and trimethoprim is minimally metabolized in the liver. primarily excreted in the urine unchanged and has a half-life of 8 to 10 hours. For the pharmacodynamics, trimetoprim is effective in treatment of respiratory, ear, and sinus infections caused by Haemophilus influenza and Moraxella naturalis. For the safety, the side effects are hypersensitivity, nausea, vomiting. More rare effects are granulocytopenia, thrombocytopenia, aplastic anemia, megaloblastic anemia, leukopenia, crystalluria, and hematuria. For the suitability, contraindication, hypersensitivity or a passover allergy. For the FDA pregnancy category is a D, so it's not an option due to congenital abnormalities. Liver parenchymal damage, jaundice, hepatic failure, renal insufficiency, hematological disorder, and neonates less than 6 weeks of age. About the interaction, it competition with warfarin and methotrexate for plasma protein binding, increase plasma levels of this drug. But the cost is for cotrimoxazole 480 milligram is only about 500 rupiah per tag. That's all. Okay, so the conclusion is using from the penicillin group, amoxicillin 80 to 90 milligram per kilogram per dose divided into 2 doses for 5 days. If allergic to penicillin, change into cephalosporin. The first line is safety near. If there are no improvement of symptoms after 48 to 70 hours, change to amoxicillin with clavulanate 90 milligram per kilogram per day. Amoxicillin with the clavulanate is 6.4 milligram per kilogram per day, 2 divided dose. In penicillin allergy, change to ceftriaxone 3-day and clindamycin 30 to 40 milligram per kilogram per day in 3 divided dose.
Hello, my name is Putu Ayudhea Pururaswini Athiyah. My name digit number is 2202511161. Based on this patient, Asweni was taken by some medicine that prescribed below. For antibiotics, is amoxicillin dry syrup with 250 mg per 5 ml dose preparation, and it needed 3 bottles of syrup, mixed in aqua. Drink every 2 times a day with a dose of 1 single drink is 2 and a half spoons. For ibuprofen in syrup with dose preparation 100 mg per 5 ml, need 2 bottles of syrup and drink it every 2 times a day. With dose every single drink is 1 and a half teaspoons. And for the other information such as doctor and patient identity has listed on the receipt. That's from me. Thank you.
Hello, my name is Adellya Pramesty with the last 3-digit number 165, and I am gonna explain the evaluation. Next. Monitoring and when to stop the therapy. Prescription of antibiotics in AOM cases is quite high. Although it is useful, antibiotics has little impact on patient recovery. By that, AOM has caused a lot of antibiotic resistance. Therefore, the usage of antibiotics must be according to the guideline. From literature research, we get key points about evaluating, monitoring, and when to stopping the therapy. First, refer to otolaryngologist for better examination, assess, treat, and observe patient individually, comprehensive physical examination, history taking, and decide AOM severity degree precisely. Use analgesics to reduce autolgia and antibiotics if needed to improve clinical findings and also reduce autolgia duration. Observe 3 to 4 days before giving antibiotics for mild cases. High dose of antibiotics is initial treatment for moderate cases. Stop analgesics if pain significantly reduced for 3 days. Stop antibiotics if patient recovered. The usage of antibiotics should be more than 4 days. Further observation after the therapy stop is still needed. The next one will be explained by my friend.
So allow me to introduce myself first. My name is Zulfikar A. With my last three-digit number is 166. Next slide, please. So according to guide to good prescribing by World Health Organization, there are two steps before we giving information or education or counseling to patient. The first step is we have to make personal formulary first. It includes, it contains some of information of the drug, like effects of the drug, dosage, side effects, and warnings, etc. And then after we make our personal formulary, and then we have to make a summary. We have to summary the explanation of the information, the drugs, to the patient. Next slide, please. So this is the picture of personal formulary of ibuprofen. As we can see, there are contains dosage information, like the pain management is 3 times a day, and etc. And then what information we can tell to the patient, like the effects of the drugs and instructions how to take drug and warnings of the drug and future appointment. And the future appointment, it should explain when we should the patient when the patient could come back to clinic. And next slide, please. And this is the example of personal formulary of amoxicillin. It is same as previous. It contains dosage, information of the drug, like what kind of effect of the drug, side effects, and then instructions of how to take the drug, warnings, and next appointment. So the next slide will be explained by my colleague.
Hello everyone, my name is Cendrawan Han Santoso with my last 3-digit student number 170. For communication, information, and education, first we must tell them what are the effects of the drug. Based on the symptoms and physical examination, the diagnosis was acute otitis media sinistra. So, effects of the drug, for the first drug is amoxicillin, which is effective for the bacterial infection, and ibuprofen for the pain reliever. For side effects of the drugs are hypersensitive reaction, serious hematologic reaction, nausea, and vomiting. Instructions with the drugs. First, ibuprofen is orally 2.5 dose for the original spoon, 3 times a day for 5 days after, and should be taken after meals. For amoxicillin, it is also orally 1.5 teaspoon, 2 times a day for 5 days as well. For warnings, it is that the person should not stop taking the drug even if all the symptoms are already gone. It is to make sure that it is to go to the nearest clinic immediately. For next appointment, we must tell the patient to come back after 5 days of treatment or to come back earlier if there are any serious allergy symptoms. And the last is to make sure that all that we have told the patient is clear and make sure the patient understands what is told to them. If there are any questions, we can explain again and confirm again to know that the patient understands it totally. Next. Thank you. This is all for our student project.